Professor Dr. Narendra.
What is going to happen? But this kind of disease, what happens is, even if we try to look at the cardiovascular disease mortality itself, almost one-third of it is attributed to those patients. They have hypertension as an etiology. So we all are aware, antihypertensives we are trying to take. So what is the motive? Yes, we are trying to treat the hypertension. But other than that also, are we trying to think for something else? I think we all should think about that as well. So what should be the thing, what we should be thinking? It is the mortality benefits, the morbidity benefits, and also what about the agent itself which we are going to take for treating those hypertension in fact. So I think we all are very much aware one of the main mechanism which is really comes into play regarding the pathophysiology of hypertension treatment is RAS. So RAS, what happens is RAS, it comes into picture with especially two group of drugs. The most commonly used ones are ARBs and also the ACE inhibitor. However, when we try to talk about its mechanism of action, there is a substantial difference. What is it? So what has been happening is, even especially in the last 3 decades, as already Sir said it, Dr. Bharti and also Sir also said it, Dr. BP Singh, there are some trials. What has been trying to accumulate those evidences and which has been coming up time and again, and I will also show you my personal connection as well with that. So what has been happening is, value trial was one of the first ones which shed a bit of light on the controversy, and later on the paradox concept came, and of course a lot of recent meta-analysis also started coming up which showed that evidence, as in 21st century what we practice is called as evidence-based medicine. So if we are trying to do anything, we are trying to give any medicine or whatever we are doing, there has to be an evidence. And if there is no evidence, I don't think so it makes sense to practice that as well. So what happens is this, in this slide as well we can see it very clearly. So when we try to compare the valsartan-based regimen and also the amlodipine-based regimen, there is a significant difference in the RR of the myocardial infarction. What is that? So what is happening is the patients who were taking the valsartan group, there was a 19% higher risk for in terms of a single parameter, which is myocardial infarction. Same way, this is what is called as a forest plot. So what happens when we try to see over here, we can notice it, there is almost a difference of a 12%. So the people who were on ARB therapy compared to the ACE inhibitor, 12% higher risk was there. And this was one of the papers. The first paper which came and which showed literally, do the angiotensin receptor blockers tend to increase the risk of myocardial infarction? I think we all will be saying definitely yes. I think they changed that presentation in which my slides were there, like 2 or 3 of them. I wanted to show from some of my meta-analysis. Anyways, now coming to the topic itself. Anyways, no, it's okay. So what happens is, what is ARB-MI paradox? So what is literally the paradox? So what happens is, we all are very much aware, we tend to use these kind of drugs, especially for those patients who are already at high risk of those comorbid conditions and even the mortality. Those people who are literally at some of those patients are at their end stage of their life as well. So what happens is, when you try to keep on following those patients on these parameters like the myocardial infarction or the other parameters as well, and now I'll give you a little bit inner clue as well. So I did a meta-analysis of comparing the NOACs way back in 2012, and I had published it in International Journal of Cardiology in 2012. So I was comparing dabigatran versus warfarin was my first publication. Second publication was rivaroxaban versus dabigatran versus warfarin. Even in that meta-analysis, which comprised more than 5,000 patients, we came across the ARBs tend to increase the risk of not just MI, but also cancer risk. In fact, later on as well, there was some more meta-analysis which showed one of the lung cancers was one of the ones which was significantly associated with ARB intake. And the controversy why it started coming up was, it seems 14 to 15 years back, none of the people, even in the review board commission as well, in the hypertension recommendation commission, they never used to think of lung cancer as a significant cancer, not at all. And that's why it never figured much, but there are some publications. Now coming back, because the slides were omitted, that's why I had to speak on my own. Anyways, now coming back to the slides. So, whatever is happening in our body, there has to be a mechanism, and that's why we study medicine, right? So what is happening even in this mechanism as well? I think this is one of the first slides we all have been going through time and again. So what happens is, angiotensinogen gets converted into renin, which gets converted into the angiotensin 1, and the ACE, the angiotensin converting enzyme, is the one through which the angiotensin 1 gets converted into the angiotensin 2. And this is the same mechanism. If there is ACE inhibitor, it tends to increase the concentration of the bradykinin through the kinase. And that is also another mechanism due to which some of the most common side effect of ACE inhibitor, which is called as cough, tends to happen. So in this as well, what happens is the angiotensin receptors are also of different types. Different types, namely 1, 2, 3, and 4. So what is happening is over here, ACE inhibitor tends to stop the conversion of the angiotensin 1 to 2, AT2 receptor. And what is the mechanism for the angiotensin 2 receptor? So AT2 receptor has a very significant effect, not just only on the cardiac cells, but also the peripheries as well. So they are related possibly to 3 mechanisms, what is called vasodilation, anti-proliferation, and also apoptosis. I think we all are very much aware apoptosis is the programmed cell death. Is it? This is what is going to show. So let's see. What about the clinical evidence? Clinical evidence has also been coming up. So as I already said, in fact, the negative feedback loop comes into play, and there is an increase in the level by almost several folds. This is not just one or two, in fact several folds. And that is why when we try to see on an overall clinical picture as well, the mortality also comes. So what happens is, as I already showed you, so it tends to promote plaque rupture by augmenting the MMP1 enzyme in fact, and it is on a dependent basis. Dependent basis, what it means is, higher is the level of the angiotensin 2 receptors, more is the plaque rupture as well. So if there is more plaque rupture, what is going to happen is more myocardial infarction. So then, even on a molecular basis as well, what happens is it tends to aggravate the risk of the coronary artery disease in an immature way. So what is happening is younger people may have a higher risk of the myocardial infarction as well. So this is a very beautiful but nice slide. So what happens is, if you try to compare the two groups over here, so what happens is it not just only affects the plasminogen activator inhibitors, in fact, even on the parameters like the insulin resistant hypertensive ACE inhibitor tends to have a positive effect. So, oh yes, so this was the meta-analysis I was talking about. So with my Australian colleagues from Westmead Hospital in Sydney, we were trying to combine up all those data way back in, as I said it, so in 2012 itself, like almost 6 years back. And during that time itself, we were trying to do the comparison. And once we got it published, the editor wrote back to us, can you try to also include the other NOAC? So during that time itself, in the West, irodoxaban was already pretty commonly used. And then when we started writing up our second paper, we started also looking at the other comorbid conditions. So that publication is going to come out very soon. So that was the time we noticed these two factors. As I said, cancer risk, especially lung cancer, and also the MI risk as well. So what was happening is, as I said, we follow what is called as evidence-based medicine. So even for this meta-analysis as well, this is another meta-analysis, which was published in Circulation way back in 2006 itself. So what happens is, they saw that ACE inhibitor, they tend to reduce the risk of the coronary heart disease by almost 10%. However, ARBs, when they try to make a ratio of the blood pressure compared to the coronary artery disease, no, it doesn't happen. So what really happens is, so they try to put up a plot like this. And if you try to look on these different multiple trials, so that is what is called as meta-analysis. Meta-analysis, you try to put up a lot of those systematic reviews all together, and then you can see on an overall picture. And what do we see it over here? If you try to read the fine lines in simple words, there is 15% risk reduction in myocardial infarction and also the cardiovascular death between the two comparative comparison comparators, which we already said it. So for example, the blue circles, which we can see it over here, and the green circles as well. So versus the ARBs and the ACE inhibitor trials. This is again a very complicated forest plot, but to summarize it, the summary is already over here. So for example, the ACE inhibitor has almost nearly a 10% reduction in all-cause mortality. All-cause mortality is a very significant and a wide term in fact as well. And similarly, however, for the ARB, it's the opposite side of the fulcrum. So what it means is there is no significant mortality reduction at all. So now the concept started coming up. Is it something really bad? So the debate has already been going on past almost 10 years. And they also try to do meta-analysis of different clinical trials as well, like the on-target study, the transcendent study as well. And the evidence started coming up that they started telling as well that yeah, it can be a little bit controversial as well, that yeah, the paradox does exist, but not everything is really going to support it. So again, in the European Heart Journal, one of the other publications came as well, when they tried to see for the meta-analysis for all the different individual parameters with the ARBs versus the comparators. So for example, for the ACE inhibitor, there was of course a reduction in the global death, cardiovascular death, stroke, myocardial infarction. But if we try to see for the ARBs, what is happening is there is 8% raise in the myocardial infarction. And even for the global death as well, 1% is higher. Even the cardiovascular death as well is 1% higher. So this was another Bangalore S et al. So he's basically from Karnataka, based at Bangalore, but practicing his cardiology in US in fact. So even in that as well, same evidence was ANC. So what can we do? So what will be happening is again, as I said it, so even on the basis of the Transcend trial, this was another landmark trial as well, they tried to do the analysis. So even in this, when they tried to look all the data in very detail, they saw that there is no significant reduction in primary composite outcome of cardiovascular death, myocardial infarction, stroke, or even the hospitalization of heart failure patients. So what is happening is evidence is there quite a lot, not just head-on, but even meta-analysis as well. So what happens is there is no detectable beneficial effect for the outcome of myocardial infarction or the cardiovascular mortality by the ARBs. Unlike ACE inhibitor, this is a very harsh word, normally we should not use such harsh words. There is no cardioprotective effect from the ARBs even when compared to placebo. So there are a lot of data over here to summarize it and to make it easier for everyone. On an overall basis, what is happening is yes, there's 9 to 11% risk reduction in all-cause mortality with significant p-value. Same way, 10 to 17% risk reduction in cardiovascular mortality as well. Even for myocardial infarction as well, almost 20% risk reduction when the ACE inhibitors are being used. So to summarize, what is happening is when ACE inhibitors are used, there is definitely reduction in the incidence of myocardial infarction and also the cardiovascular death. And of course, even on the parameters of the blood pressure reduction. And the meta-analysis also, a lot of meta-analysis are there, several are unpublished, which will be coming up very soon, are also supporting this concept. So the practical guidelines should also try to recognize the unique cardiovascular benefits which are for the different antihypertensive agents before adhering to an agent in fact. And we should not try to forget, we are trying to use antihypertensive drugs, of course, to lower the blood pressure, but also to reduce the cardiovascular mortality and also the morbidity.